Our next speaker is probably very familiar to you all, particularly from his pathology reports, which range from this tumour when it's local in Belfast to this very interesting case if it's NHS, or this fascinating case if it's for a private hospital. Is a very great friend of mine, and again another person who I was at medical school with, Glenn McCluggage. Glenn has really established himself as one of the top pathologists in the world in gynae pathology, and we're really very lucky to have his expertise. He tells me that he's now got over 700 publications, and he is going to have a valedictory meeting later on this year organised by the BAGP. So it's a great pleasure to invite Glenn to talk to us today. Thank you.
Okay, thanks, Stephen, for the introduction, and I'm very glad to be here in Birmingham once again. So, what I'm going to talk about is I'm really going to try to roll two talks into one. I'm going to talk about the molecular classification of endometrial cancers. That'll be most of the talk, and maybe the last 5 minutes or so I'm just going to talk about the FIGO 2023 staging system. You know, what we've done in the UK and what might happen going forward. So, you know, it goes back, we've known for a long time that endometrial cancer is not a single disease. This is the very famous Bachmann type 1 and type 2 classification. Dr. Bachmann was actually a gynecologist. He wasn't a pathologist, and you know, the type 1, the more common, the estrogen-driven endometrioid, and then the type 2 in older women, the more aggressive serous types. And of course, as time went on, you know, the molecular events in these tumours were discovered. But of course, pathologists certainly never used this type 1, type 2 classification because it was more a conceptual thing, but there's too much kind of overlap between individual tumours, and some tumours don't fit neatly into this type 1 or type 2 tumours. So, you know, this is our current WHO classification of endometrial cancers, and we're in the process of updating the WHO classification, but this will not change. It'll probably not change at all. So these different types of endometrial cancer, as pathologists, we make the diagnosis really by looking down the microscope. It's morphology based, and we often use immunohistochemical markers to help distinguish between the various tumour types. But unfortunately, you know, and there are several papers showing this, especially with high-grade endometrial cancers, there's really significant inter-observer variability amongst pathologists in the classification. You know, if you show a very poorly differentiated tumour to 10 pathologists, some of them may think it's a serous, some may think it's a grade 3 endometrioid, some may think it's an undifferentiated carcinoma. And of course, with immunohistochemistry, you can improve this, but there still is significant inter-observer variability in diagnosis, especially with these high-grade tumours. So you all know about the TCGA study, which was published over 10 years ago in Nature. And this really used, it was actually a series of just endometrioid and serous carcinomas of the uterus drawn from various institutions. And they did a lot of complex molecular work. And again, you'll know this, they came up with these 4 molecular types of endometrial cancer. And a lot of studies have replicated this since then. You know, at the top here with these poly-mutated tumours with a very, very good prognosis. At the bottom, you have the copy number high tumours with a poor prognosis. And then these 2 intermediate groups in the original TCGA, they were called MSI and copy number low. Now, they do go by different names, which sometimes results in a bit of confusion. And what I've highlighted in bold here is what is kind of the most usual terms and what I'm going to use for the rest of this talk. So I'm going to talk about poly tumours, mismatch repair deficient tumours, P53 abnormal tumours, which are the copy number high, and then the no specific molecular profile. So these are the different groups. And in the original TCGA publication, you can see the percentages. The POLE, the good prognosis, was only about 7.3%, and the no specific molecular profile, 38.8%. But one thing to remember is that, and I'll come back to this, is that this was not a population-based study or anything. This was just a series of cases of endometrioid and serous carcinomas gathered from various institutions. So although those are the figures, they don't necessarily reflect what's going on in the population, and I will come back to that. So you can see, I've already mentioned that histopathological diagnosis of endometrial cancers, it's to some extent it's a bit subjective, but this molecular classification really it's objective, and these four groups are largely non-overlapping. There are a few exceptions, which again I'll come back to. And, you know, we're now in an area of personalized treatment for endometrial cancers and other cancers. So, you know, we don't treat all endometrial cancers the same. You know, age is important. Traditional pathological parameters like tumor grade, tumor stage, LVSI are always going to be important. But with these new molecular groups, there is this potential for more personalized treatment. For example, de-escalation of treatment in POLE tumors. The P53 abnormal tumors, they seem to be very sensitive to chemotherapy, and it also opens up other avenues like you might use for tubo-ovarian high-grade serous carcinomas like HER2 and HRD, the immune checkpoint inhibitors and mismatch repair deficient tumors. And then again, I'll come back to it, the no specific molecular profile is a kind of heterogeneous group of tumors which we need to look into further. So now I think we're at a bit of a crossroads, you know, because we now know the importance of molecular typing of endometrial cancers. And we have all these recommendations out here, you know, saying, yes, you should use molecular classification, but also all these recommendations, you know, they acknowledge that it's not always easy to do, especially with the availability of molecular techniques. So now I think we as pathologists and as our MDT teams are beginning to have to try to use molecular classification and base our treatment of patients on this. And this was a step forward. This was just a couple of years after the TCGA. This was a paper from the Vancouver group really come up with this. It's almost a surrogate molecular classification of endometrial cancers, which really requires you to do MMR and P53 immunohistochemistry in all endometrial cancers. But for this surrogate, you still need to do POLE mutation testing. Of course, that is not always widely available in all pathology labs. It has to be sent out, and it can be some time before the result comes back. And this is really the PROMISE algorithm. All endometrial cancers, regardless of type, first of all, you have to look for a POLE mutation. If there's a pathogenic POLE mutation, it's a POLE mutant endometrial cancer. If the POLE is wild type or a non-pathogenic mutation, then you look for the MMR status. If it's MMR defective, this is an MMR deficient endometrial carcinoma. If it's MMR proficient, you look at the P53 immunohistochemistry. If that is abnormal, it's a P53 abnormal endometrial cancer. And if the P53 staining is what we call wild type, then this is a no specific molecular profile endometrial cancer. So this is really what many labs do, this kind of surrogate of, it's not pure molecular testing, it's more a surrogate, although in Belfast I'll come back to what we do in all these endometrial cancers. So of course crucial to this is that when we do P53 immunohistochemistry, we're not actually proving there is or isn't an underlying P53 mutation within the tumour. You're really just kind of looking at the pattern of staining, which is quite predictive whether an underlying P53 mutation is present. Now, I still see a lot of pathology reports P53 is positive, P53 is negative. This is not how P53 immunohistochemistry should be reported. It should be reported as wild type, which predicts there's no underlying mutation, or mutation type, which predicts that there is an underlying mutation. And unfortunately, P53 staining, it is quite fixation dependent, which is why it's much better to do in endometrial biopsies than resection specimens. So this is just a paper we published a few years ago giving some guidance to pathologists on how to interpret P53 immunohistochemical staining. And it's not just positive or negative, because this is what we call wild-type staining, where some of the nuclei are positive, but a lot of them are negative. And this type of staining really predicts there's no underlying P53 mutation, whereas you can get these three different types of mutation-type staining. One where almost every nucleus is positive, one where every nucleus is negative, and then this rare type of cytoplasmic mutation type staining. So it's not just positive and negative. When you look at a series of, this was tubo-ovarian high-grade serous carcinomas with molecularly proven P53 mutations, you can see about 2/3 of them exhibit this diffuse mutation type staining, about a quarter are null. A small percentage of this cytoplasmic staining, but important for pathologists at least to recognize you can, in rare cases, get wild-type staining with P53, but there actually is an underlying P53 mutation. And then MMR immunohistochemistry we do in all endometrial cancers, and in many ways this is actually better than molecular because it's quicker and it can suggest what gene is involved. And when we started doing MMR immunohistochemistry in endometrial cancers, it was really to triage for possible Lynch syndrome. But there are now lots of reasons for doing MMR immunohistochemistry. It's not just for Lynch syndrome. It can be useful in diagnosis. For example, if you're not sure if an endometrial cancer is a serous or an undifferentiated carcinoma, if it's mismatch repair deficient, it's probably not a serous carcinoma. It's predictive, MMR deficiency is predictive of response to immune checkpoint inhibitors. It's important for the molecular classification. It's important, these mismatch repair deficient tumors are often not very chemoresponsive. And also the other reason for doing it up front is what has been happening is that clinicians 5 years later come back and ask you to go and do the MMR. And it's very difficult to retrieve the material and go and do it. So if you have it done up front, this can kind of save time and effort. But again, just like P53 staining, pathologists need to know how to interpret mismatch repair immunohistochemistry. So this is just the kind of normal intact staining with all 4 mismatch repair proteins. And really, when you have mismatch repair deficiency, the tumor cells, the nuclei become negative. So you must make sure your stain is working. These positive cells are actually endothelial cells lining blood vessels. So this is your positive internal control. So, about 25 to 30% of endometrial cancers are mismatch repair deficient. And the vast majority of those are sporadic. They're not due to underlying Lynch syndrome. So in unselected endometrial cancers, maybe some in the region of 5% of patients will have an underlying Lynch syndrome. And there are different kind of patterns of MMR loss by immunohistochemistry. And, this would be the most common loss of MLH1 and PMS2. And almost all of those patients don't have Lynch syndrome. But if you get loss of these ones, MSH2 and MSH6, then there's a very high likelihood the patient has underlying Lynch syndrome. And of course, these patients need to get kind of sent for genetics to work this out. And this is just a nice, if you're interested, this is it's on the BAGP website, a nice kind of a bit about how to interpret MMR immunohistochemical staining. It is a bit controversial, but probably amongst mismatch repair deficient endometrial cancers, those ones, which are essentially, these are the ones which are not associated with underlying Lynch syndrome. They actually seem to be a bit more aggressive than mismatch repair deficient endometrial cancers in patients with Lynch syndrome. So another question which sometimes comes up, if you get a recurrent endometrial cancer and it's biopsied, should you repeat the MMR immunohistochemistry? And we've actually started to do this because it's rare, but there are a small number of cases which are initially mismatch repair proficient and the recurrence becomes mismatch repair deficient, and it may open up other therapeutic avenues. So I think it is worth repeating the MMR immunohistochemistry if the original tumour was MMR proficient. So it's all, we have got the P53 and the MMR immunohistochemistry, which are a reasonable surrogate of the underlying mutation status, but POLE, we don't have an immunohistochemical surrogate. So for POLE testing, the tumour has to go for molecular testing. Most of us use a kind of, it's part of an NGS panel. There are some standalone POLE mutation testing. But, you know, one of the problems is getting this done in some places and getting the results back in a clinically relevant time. POLE cancers, you know, they're really interesting tumours. If you look down the microscope, they're often very nasty looking. They look like very high grade, and often a lot of tumour infiltrating lymphocytes, often a lot of LVSI, but the prognosis is still very good. This is a POLE mutated tumour. You can see all these tumour giant cells and all these tumour infiltrating lymphocytes, and it's very easy to make a misdiagnosis of a serous carcinoma. These are the pathogenic POLE mutations. They're currently only 11, but you know they're likely to be more described. And this is a meta-analysis from the Vancouver group a few years ago. You know, all the published cases of POLE mutated tumours. There are only 3 disease-specific deaths in this whole group. And just to mention that the original TCGA, as I said, only dealt with endometrioid and serous carcinomas, but POLE mutation also portends a good prognosis on these other morphological variants of endometrial carcinoma. You do get occasional what we call double classifiers, and these are very often POLE mutated tumours. Because of the high mutational burden, they get secondary, for example, P53 mutations during tumour progression. And what we think is that the prognosis is still the good prognosis of the POLE mutated tumours because, for example, the secondary P53 mutation, it's not a driver mutation, so the prognosis still seems to be quite good in these. And this is what you tend to get in the immunohistochemistry in these. You get actually this clonal loss of, this is one of the mismatch repair proteins in a POLE mutated tumour, whereas bits of the tumour it's retained and other bits it's mutated. And similarly, you can get these secondary P53 mutations. This is another POLE mutated tumour. Most of the P53 is wild type, but you pick up these small foci of mutation type staining. So just a few other observations, you know, regarding I've already mentioned the TCGA. It can be applied to all endometrial cancer types. One thing there's a lot of focus on now is this no specific molecular profile group because it's got an intermediate prognosis. And probably why it has an intermediate prognosis is that within this group, there's a lot of your barn door low-grade endometrioid carcinomas which have a good prognosis, but also in this no specific molecular profile, there's some of these aggressive tumor types like clear cell carcinomas, like mesonephric-like adenocarcinomas. So a lot of them are in the no specific molecular profile, which kind of worsens the prognosis slightly. So it seems that, you know, within this no specific molecular profile group that ER might be, you know, ER negativity may be a poor prognostic indicator, possibly because it's picking out these things like clear cell, etc. And actually, although we always grade tumours, it's kind of becoming apparent that grading is not important in POLE tumours. They all have a good prognosis. Grading is not important in P53 abnormal. The prognosis is poor. It's probably not actually of prognostic significance in the mismatch repair deficient tumours. Grading, I'm not saying we're going to stop grading all these tumours, but grading is really only important in the no specific molecular profile group. So the BAGP have had these recommendations for a lot of years now, ER, MMR, and P53 immunohistochemistry on the biopsy specimens of all endometrial cancers. Much better to do in biopsies. The fixation is much better. And of course, you can do other markers depending on the differential diagnosis. I've already mentioned why MMR immunohistochemistry in them all, why ER and all. I've already mentioned this possibly prognostic and the no specific molecular profile group. but it can also maybe help you to pick up subtle tumours which you might not have missed in the histology. If you have what looks like a low-grade endometrioid, it's ER negative, you might begin to think, is this something different? Is it a serous? Is it a mesonephric like adenocarcinoma? And again, when the tumours recur years later, the clinicians might come back and ask you to do ER. If you have it up front, that again can save time. And these are the reasons for doing P53 immunohistochemistry, and all I've already kind of mentioned most of those. This is on the, I think it's still on the BIGP and BGCS website, In Belfast we do polio and all, but this group of tumours, basically the low-grade stage 1A endometrioid carcinomas with no or focal LVSI, if they're ER positive, they're not going to get adjuvant treatment, so you could omit POLE mutation testing in these, and this is what some laboratories and some MDTs do. And if you use that algorithm, you can avoid doing POLE mutation testing in about 38% of your endometrial cancers. So, this is just, within the different types of endometrial cancer, the different molecular groups, for example, high-grade endometrioid, these are what we call promiscuous tumours, that all 4 molecular groups are represented in there. And again, in this group of grade 3 endometrioid adenocarcinomas, the molecular classification is very prognostic. The POLE have a very good prognosis. So this is, we started a few years ago instituting, I'll take you through what we've done in Northern Ireland. We published this in histopathology last year. So we've been doing the immuno for a long time, and then we started sending all the endometrial biopsies throughout Northern Ireland with a diagnosis of cancer for this NGS panel, which includes POLE, which includes P53 genes, which includes MSI testing. The results we get within 2 weeks, and we're speaking to a few guys, Stephen and Mark, etc., and Elaine. I think the clinicians, the medical oncologists are now beginning to take, the molecular classification into account at our MDTs. And basically, we actually think this is probably the first true population-based study in the world, because in Northern Ireland, it's, there are 4 pathology labs. We all have a linked system, so we can get it all together. So, this is probably the first true population-based study within the world. And actually, the results come out very, very similar to the TCGA, about 7.3% POLE, 45% no specific molecular profile, and then these 2 groups in the middle, and about 6.5% were double classifiers. Why do we use the biopsies? They're better fixed, makes the immuno and the NGS easier. They're often a more pure tumour population within the biopsy. And you can have the information already when you're reporting the hysterectomy specimen, and even, if the clinician wants to know the molecular classification before the surgery, it will usually be available. So just, all our POLE mutated were low stage endometrioid, but again, quite a significant number of them were high grade. And I'll not dwell on this, but there is a good correlation between MMR, immunohistochemistry, and MSI testing. But if you can do both, sometimes one test will miss it and the other will pick it up. So it's better if you can kind of do both. And again, similarly, there's quite a good correlation between the P53 immunohistochemistry and the P53 mutation status, although sometimes the molecular actually picks up P53 mutations, which again, it's not quite, are these significant, especially if they're very low VAF, they may just be secondary mutations. And this is just a sample of our molecular report where you get the POLE and the TP53 results. This patient had a POLE mutation, a P53 mutation, and down at the bottom, it's a POLE tumour with a subclonal P53 variant, likely as a consequence of the POLE mutated tumour. And then, we can kind of integrate all this into our final histopathology report and come up with a molecular classification. So just in the last 5 minutes or so, I'm just going to run through a few observations about the FIGO 2023 staging system of endometrial cancers, which kind of was published quite suddenly and I think took a lot of us by surprise. And, traditionally, staging is, it's how far the tumour has spread. It's just anatomic. It doesn't take into account other factors, but actually TNM have introduced non-anatomic parameters in some tumour types, although not any of the other gynecological tumours. But the major changes, of course, in FIGO 2023, it was no longer just about anatomic spread. It incorporated the tumour type, the tumour grade, LVSI, and also molecular parameters, and really this resulted in a lot of changes to the FIGO staging. And I would say this is not really a staging system. This is a risk stratification system, but this is actually what FIGO intended, and they actually used the ESCO-ESTRO ESP guidelines as a template. So using the FIGO 2023, and I'll come back to right at the end, we don't use it, but for stage 1, currently it's only inner or outer half, but now with the new FIGO, if it's invading the myometrium at all, you have to take into account LVSI, you have to take into account the tumour type, you have to take into account the tumour grade. And similarly, stage 2, it's not just is it into the cervical stroma, it can be stage 2 just on the basis of substantial LVSI or a high-grade tumour. And a few changes to stage 3 introduced, like the other gynae tumours, the micro and macro metastases, and isolated tumour cells don't upstage, and a few other changes. So there were major changes, and of course one of the ones in stage 1 and stage 2 tumours, if it's a POLE mutation, then it's stage 1A, even if it's in the cervix, even if it's in the outer half of the myometrium. And similarly, even if it's if it's a high-grade carcinoma invading the inner half of the myometrium, it's stage 2, automatically stage 2C. So this is just a paper we wrote. A few, as mainly pathologists, were kind of quite concerned about this new FIGO staging. And this paper we wrote, it wasn't meant to be just a barn door criticism of the new FIGO. We tried to present the advantages and disadvantages. Some of the advantages, I think the nodal involvement, the nodal changes were good. Some of the different substages, for example, different peritoneal disease will facilitate accrual of information. And as to be expected, this new staging system is certainly much more prognostically significant stage by stage compared to the old system. But of course, this is to be expected because it's really a risk stratification. This is just one paper showing that it's much more prognostically significant, and actually shows, if you compare the old to the new, about a quarter of tumours will be upstaged from stage 1 to 2 just based on what they call aggressive histological types, and a small percentage, mostly POLE-mutated tumours, will be downstaged. But there are a lot of disadvantages, I think. One is that it's much more complicated. It's not intuitive. The number of categories has gone up from 9 to 21, and I think this makes it difficult to understand. It's confusing for patients, and it's going to make it very difficult to compare old and new cohorts because the staging is completely different. I think you may think, people, I think now that pathology doesn't just go into the machine and the answer comes out, but there's a lot of these variables that are in the new FIGO staging are subject to a lot of inter-observer variability. And just one I'm going to talk about very briefly is substantial LVSI, because all these recommendations, some of them say 5 or more, some of them say 3 or more, some of them say 4 or more, and none of them actually say is it just on one slide or do you add together on the all slides. So everybody's doing something different with regard to is there substantial LVSI. And if I work in Belfast and we very rarely diagnose substantial LVSI, all our tumours will be stage 1. If you go to Manchester, where they diagnose a lot of substantial LVSI, all their tumours will be stage 2. So there'll be completely different staging just for the same tumour. This is just a review we published regarding LVSI and endometrial cancer. So lots of kind of pitfalls, and we really are all doing different things. The molecular parameters essentially means FIGO staging cannot be used in countries where these resources are not available, and in many of these countries they don't even have immunohistochemistry to actually type the tumours. So it's not going to be applicable in some places. So this is what can happen at an MDT. We have a tumour, it's reported at the cancer unit, a grade 2 endometrioid cancer, into the outer half of the myometrium 1B, comes to the cancer centre, it's reviewed, it's thought to be a stage 3 tumour, it goes up to stage 2C, and a week later the POLE comes back, it's POLE mutated, it's back to stage 1A. So there is this kind of risk of a stage shift scenario. We also think, there's a lack of supporting evidence for a lot of these things that FIGO have introduced, and there's no mention of, external reviews, feedback. There was no opportunity for feedback from various societies. And, one of my big bugbears, FIGO, the staging system, is pathological. There was one pathologist involved. He was acting on his own, he was told he wasn't allowed to liaise with, for example, the International Society of Gynaepathology, and this is part of the trend by FIGO that pathologists have been admitted from a lot of these new staging systems. So I think going forward, and I've heard on the grapevine that FIGO are actually doing this. They're going to start to work with pathologists and other societies, and I don't know what stage they're at, but they're going to revisit this new FIGO staging system and maybe modify it slightly just with the new anatomical parameters, and then use the kind of other parameters almost as trees coming off, but not part of the actual staging. But that remains to be seen. This is what we decided to do in the UK, the BGCS under Stephen and the BAGP. We had decided that currently we wouldn't introduce FIGO 2023, and we would review this. We did have some deliberations that we're probably still not going to recommend FIGO 2023 to be used, but just to wait. And people have said, they're using it everywhere else in the world. They're not using FIGO 2023 everywhere in the world. They're not using it in the USA. They're not using it in many places throughout the world. They're still using the old FIGO system. So thanks for your attention, and if there's time, I'm happy to take questions. I may have gone over a bit.
Fantastic talk, Glenn. Thank you very much. We'll just take one question if any. Yes, thanks.
Thank you for such an informative talk. I just had one question about atypical hyperplasia and molecular profile. Do you start to see P53 mutations or MMR deficiency in the atypical hyperplasia? And do you think that might be prognostic in future?
So yeah, people have looked at that. So P53 mutations probably very uncommon because these are mainly, you're talking about atypical hyperplasia, you're mainly talking about the precursor of endometrioid, and the endometrioids can be P53 mutated, but it's a secondary P53 mutation kind of late on. But if you look at let's say you take 100 cases of atypical hyperplasia and stain them with MMR proteins, about 5% will actually have loss of MMR proteins right at that stage, which is kind of less than the 30% of, if you use endometrioid cancer. So yeah, a small percentage do. We don't do MMR immunohistochemistry in cases of atypical hyperplasia. You could argue that maybe you should, because there are those 5% which are abnormal, and a small number of them might have Lynch syndrome, but we don't tend to do it.
Okay, thank you.